Fill the nebulizer chamber to the indicated line with distilled water. Draw up and add the desired amount of saline solution as determined by your specific study protocol to the medication cup. The concentration of saline and amount may vary, so refer to your protocol for specific instructions. For this induction, we'll be drawing up 40 milliliters of hypertonic saline. Place the filled medication cup gently and firmly in the nebulizer chamber. Use binder clips to secure the nebulizer chamber. Use 7 sections of Cora Flex tubing to reach the booth. Attach the tubing to the medication cup. Attach the plastic T adapter and add 1 section of Cora Flex tubing that has been cut in half to each side of the T adapter. Place a cup in the booth for saliva and a sterile specimen cup for sputum collection. Label the cup with the participant's initials, ID number, date, and visit number. Make sure there are some tissues for the subject. Check that the equipment is working before you begin. Set the nebulizer for maximal air and maximal flow. Set the timer to beep every 2 minutes. Before beginning a sputum induction on a research subject, remember that subject safety is the most important consideration. You'll do baseline spirometry and then give 4 puffs of albuterol. Wait 15 minutes and repeat spirometry. If the post-bronchodilator FEV1 is greater than 50%, you may proceed. These criteria may vary by protocol, so refer to your protocol for specific instructions. You will monitor the subject by doing peak flows every 2 minutes, so you'll need to do 3 baseline peak flow maneuvers post-bronchodilator. Choose the highest peak flow and calculate 80%. This is your benchmark. If the peak flow falls below that number during the procedure, repeat to confirm. If still below, then you will stop the procedure and measure spirometry. If the FEV1 is less than 80% of the post-bronchodilator FEV1 as well, stop the procedure and administer 2 puffs of albuterol. Follow the worksheet and the manual of procedures for detailed instructions. Make sure that a physician is on call in the event of an excessive bronchoconstriction or other adverse reaction, and have an albuterol metered dose inhaler immediately available, along with emergency supplies such as albuterol solution for nebulized treatment, an EpiPen, or an injectable epinephrine. These may vary by institution and protocol, and you should consult your institutional guidelines. To collect an adequate sample, the induction should be more than 4 minutes. The sample volume should ideally be more than half a milliliter, and it should have less than 80% squamous cells on the cell count. This can be achieved by ensuring that there is as little saliva and nasal contamination as possible, and that the sample consists of secretions coughed up from deep down in the lungs. Okay, Xavier, the procedure we're going to be doing now is called a sputum induction. It's a timed procedure that involves your active participation, and the goal is to collect a sample of sputum or phlegm from deep in your airways. You'll be doing this procedure inside of the hood. The hood can be a little loud and the screen can be a little dizzying, so you may choose to look away or close your eyes during the procedure. You'll be breathing a mist of concentrated salt water. The salt water may make you cough and may make you salivate. We want to avoid salivations and postnasal secretions from entering into the sample, so that means that you should blow your nose and spit into the cup as frequently as you'd like. This is a 12-minute procedure in which you'll be breathing on the mouthpiece. Every 2 minutes, I'll ask you to come off of the mouthpiece, spit into the cup to clear away any saliva, and then return to the mouthpiece and take 2 deep breaths. Then you'll cough deeply and vigorously to try and bring up any sputum or phlegm from deep in your airways. After that, we'll do a peak flow measurement in order to monitor your breathing. Some asthmatics may experience mild bronchoconstriction, wheezing, chest tightness, or shortness of breath, but these are rare, and we've primed your lungs with albuterol prior to the induction to help decrease the likelihood of developing these symptoms. If you do feel symptomatic, however, or are having trouble breathing at any point during the procedure, please let me know. Some sensations that you may experience during the procedure include coughing, feeling like a need to swallow, a scratchy or sore throat, or a salty aftertaste. So, in summary, this is a 12-minute test meant to collect a sample of phlegm or sputum from deep in your airways. Every 2 minutes, I will stop you, ask you to come off of the mouthpiece and spit into the cup. You'll then return to the mouthpiece, take 2 deep breaths, and then cough deeply and vigorously to try and bring up any phlegm or sputum that you can into the specimen cup. I will then monitor your breathing by having you do a peak flow. Do you have any questions?
No questions.
Okay, Xavier, let's get started. All right, put your nose clips on. Great. And come onto the mouthpiece and begin to breathe regularly. That's great, just a few more minutes. Okay, good job. Come off of the mouthpiece, spit into the cup. Good, clear any saliva. That's great. Come back onto the mouthpiece and take 2 deep breaths. Good. Now big coughs. Cough up anything that you can. Deep, vigorous coughs. Those are great coughs. Good job. Okay, we'll do a peak flow now. So big breath in and blow really hard. Good job. That was great. We can keep going. Return to breathing regularly on the mouthpiece. Discard Coraflex tubing, medication cup, and mouthpiece in the biohazard bin. Rinse the nebulizer chamber with distilled water and turn upside down to dry. Wash and soak the T adapter in Alkanox detergent for 12 minutes. Then rinse with distilled water and disinfect with Sidex OPA solution for 12 minutes or according to your institution's policy. Rinse thoroughly with distilled water once more and allow to air dry. With the vent on, spray the inside of the booth with Cavicide or disinfectant cloth such as Santa Cloth.